Good afternoon, everyone. My name is Pauline Matandon Garcia. I am the Director of Care Transition for Livingston Memorial VNA and Hospice. I will be moderating today's presentation. Today's topic is dementia awareness. So before I introduce our speaker, I'm just going to go over a few housekeeping items. Number one, our presentation today will be recorded and will be available for viewing post-presentation. If you have any question during the presentation for our presenter, please feel free to use the chat function on your Zoom app to send in your question. You can also use that same function to submit any questions or if you're having any technical issues. We will do our very best to assist you with that and also answer all the questions that you may have during the presentation. All the questions and answer will also be posted on our website post presentation. So today's topic is dementia awareness, as I've mentioned, and today's speaker is our very own medical director, Dr. Lanyard Dial. So Dr. Lanyard K. Dial is a leader in family medicine and geriatric medical education. He served as director of the family practice residency at the Ventura County Medical Center from 1987 to 2002. Since 1998, Dr. Dial has been a national leader in the Geriatric Continuing Medical Education, CME, with the American Academy of Family Physicians, AAFP. He was the chairman of the Geriatric Review course, developed and taught the geriatric section of the AAFP's Family Practice Board Exam Review course. Dr. Dial has served on the Physicians Advisory Board of the Ventura County's Alzheimer's Association. In 1986, he became the medical director of the Livingston Visiting Nurse Association. In July 2007, Dr. Dial became Livingston's CEO, president, and medical director. In June 2021, Dr. Dial retired from the CEO president position, but continues his passion as Livingston's medical director. As a longtime Ventura County resident, he works to improve the quality of medical services for the elderly, homebound, and terminally ill. Dr. Dial received his medical degree from Washington University School of Medicine in 1981. He is a diplomat with the American Board of Family Practice and holds certificates of added qualification in both geriatric medicine and hospice and palliative medicine. His faculty appointment is as a UCLA Associate Professor of Family Medicine. So, good. My pleasure. I want to introduce Dr. Lanyard Dial. Take it away, Dr. Dial.
Thank you very much, Pauline. Well, good afternoon to everyone. We're going to spend the next period of time together as part of the Livingston webinar series, looking at a topic of dementia awareness. Speaking about dementia from a medical perspective and helping you to understand some of the language that physicians are using, some of the terminology, and the underlying disease processes that happen. With that, let me screen share my slides so that together we can look at this topic. So when you're talking to a physician about the word dementia, I believe that many of you are becoming more familiar with this term. However, in a physician world, it has some specific meanings, and I want to be sure you're aware of those. It is as important to understand dementia as to look at the other cognitive things that happen in the brain, and in particular, the word we use called delirium. So I'll be differentiating some of the terminology and helping you to understand this illness. So we'll start as a first slide of the summary of what we're going to talk about. Dementia as the main topic, differentiating delirium. Speaking of an illness for you to understand called mild cognitive impairment. To do all that, besides defining them, I need to explain to you how the brain works, both structure, function, location of memory problems, some of the disease states that happen within the brain, talk to you about memories in specific and how we look at memory, how things are encoded in your brain, and the way in which we evaluate and test people who have memory loss. and then speak specifically about the major causes of the dementia syndrome, Alzheimer's disease, Lewy body dementia, and multi-infarct dementia. So that's the summary of where we're going. Let's begin with a definition. Dementia is a syndrome. That means to me and other physicians that it's not one thing, but a group of symptoms. It is not a specific disease. It's not a specific disorder. Dementia defines a syndrome or a group of symptoms that are displayed in that individual. A person with dementia, the symptoms that are common are loss of memory, in particular short-term memory, and other intellectual functional losses, such as the loss of language skills, not unable to speak, but they can't find words, they substitute words, they mispronounce words, calculation problems, problem-solving abilities, reasoning, visual spatial skills. Visual spatial skills are like putting a key in a lock, is difficult for somebody who has dementia. So it's commonly associated with some changes in moods and behavior. One of the things I won't be talking much about is depression, because depression is a very broad diagnosis. There are some people who exhibit depression with their dementia or depression before they develop dementia. But that's about all I'm going to say today about depression as it relates to dementia. And the key and fundamental thing to understand is that this group of symptoms occurring in a person is a disease. Rarely can we treat it. Rarely can we find a reason that's causing it that we can actually reverse. And most people with this disease have an ongoing problem as this disease progresses, that they lose more and more and more function. So it's rarely reversible, and most of the conditions progressively lose more function. So it's a serious and significant disease, particularly in our older population. Delirium. Delirium is a totally different type of memory disturbance and brain disturbance. So understanding the difference between dementia and delirium is important in the field of medicine, but it's important for you to understand that these two are extremely different causes and have different outcomes, so differentiating them is important. People who have a dementia are usually in a fixed state of consciousness, meaning they're usually alert, they're usually normal, they speak, they walk, they talk, they have limited difficulties with being awake or asleep. As the disease progresses, those may change, but certainly with the early diseases, they have a fixed level of consciousness. Whereas a patient who exhibits delirium will at one moment be awake and at the next moment be sound asleep. Thinking about delirium, if you think about an individual who's going through alcohol withdrawal, they will be anxious and agitated, and then they'll fall asleep. And then if you arouse them, they're anxious and agitated again. That's delirium. That's not dementia. Dementia has a gradual loss, a gradual progression of the disease. Delirium acutely comes on and acutely stops. So delirium is very different. Hallucinations are rare and late findings in dementias. They are marked in people who are delirious. They will see butterflies flying, they will see people with knives. They have hallucinations right at the beginning. They're awake at one moment, they're asleep. When they wake up, they're agitated, it acutely came on, and they're hallucinating a lot. Dementia patients are attentive to what's going on. You can have a conversation. You can show them things. They will follow along with you. A delirious patient does not focus on what's happening. They're focused on their hallucinations. they're asleep, and they won't be attentive to what you're doing. As I mentioned, the dementia patients, we don't know what causes it. We have a number of different kinds of illnesses that we'll talk about, but we really don't know what causes it. But delirium is caused by something, and we frequently have to find out what's causing it. Are they having low levels of oxygen in the blood? Are their blood chemicals off? Have we given them a medicine to make them delirious? In fact, drug-induced delirium can happen to anyone. You may take a medicine for a cold that you bought in the pharmacy, brought it home, took the medicine, and all of a sudden you went haywire. You started getting angry and upset and having hallucinations and couldn't focus on things. That's a drug-induced delirium. It comes on quickly and acutely, and if we can get rid of that drug out of your system, it goes away. So delirium is very different than dementia. Unfortunately, people use the language and they both start with D, so people get them confused. But there's no confusion in this world with the difference between these two illnesses. Now, demented patients, people who have that underlying memory loss, are more easily tipped into delirium. And you know that and see that when you think about a patient who has underlying Alzheimer's disease and then has what we call sundowning, that when the sun goes down, they develop a delirious state. They get more confused. They get more agitated. It's an acute thing that starts all of a sudden. And that's because the sun going down has caused a loss of input into their brain, and they therefore can't think as well as they did before, and they now have acute delirium. By improving the lighting in that room, by orienting them, you can take the delirium away from a demented patient. So those two are very distinct presentations of people. Then there's this third thing that I put that we've talking more about these days, and it's called mild cognitive impairment. And mild cognitive impairment is short-term memory loss, but it's early in the process of losing that memory, and it's such that the individual kind of senses they've lost that memory, and they're able to provide you with examples of how they've lost their memory. They have trouble specifically remembering names of people or meeting or the flow of conversation. Key is they can get lost in a familiar place, in their own home, in a family member's home. They usually remember recent events, but they use calendars or notes or lists to help people. This is a very mild kind of early dementia. The question is, do these individuals go on to have dementia, or do they stay in this early level? And it's important to distinguish this early level from normal age-related changes. So as we go along, keep your eye out as we discuss mild cognitive impairment, and we want to differentiate it from normal age brain and dementia and find its place in the middle of those two. So let's look at the normal aging brain. The normal aging brain typically has some memory loss. As we get older, we forget things. It's very common for the normal age brain with no disease to have short-term memory loss. And again, like mild cognitive impairment, those losses people sense and they can complain about and they can look at. Patients with dementia rarely complain of their memory loss. It's usually a family member who makes that complaint. Patients with a dementia don't usually sense they have a memory loss, whereas a person with a typical age change senses that. People with normal memory aging will search for words. They'll forget people they met. They'll find difficulty telling you a story about yesterday's television or newspaper because they can't remember exactly the location that they saw it or the name of the individual who was involved. And if you wait 5 or 10 minutes, those names will pop into their brain. Whereas in dementia, they won't remember that, and they will find words through pausings and substitutions, but they tend to talk. They don't tend to search for the words. It's said that normal age memory changes create someone who searches for words as they're speaking, whereas in dementia, people speak and they pick up words that don't correlate to what they're trying to say. They are more loquacious, is in the language of Webster Big Words. In typical aging memory changes, people may have to pause to remember directions, but they don't get lost in familiar places. Whereas in dementia patients, they get lost in familiar places. It takes excessive times for them to figure out as they went from one room to another what they were looking for, and they can't remember that at all, and they don't. And then they don't remember they were actually looking for something. So it's a very different part of your short-term memory loss. People with normal age-related changes remember most recent events. Conversations are not impaired, whereas dementia patients have a decline in recent memory and have trouble conversing. So most of us, as we gotten older, are concerned that our normal memory changes mean we're demented. But I hope you can see here the severity of that memory loss is larger, and the kinds of things you can tease out are different than people with typical memory changes. And those typical age-related memory changes begin after the age of 20. We start to not focus on things, and we forget where we put our keys or forget where we parked our car, only to say, okay, I finally remember where I put my keys and parked my car, whereas a dementia patient won't pick up to remember those things. This is a little bit of a graph with the green lines at the top representing kind of that normal aging, where time in years versus your ability to remember things is graphed. And the green line shows you kind of the experience everybody has, that as time goes along, we have a little bit of decline in our ability to remember things. But the mild cognitive impairment people in the middle start to have more serious problems with changes that become of concern to other people. However, people can stay at that level. That's the blue line. They have a more significant decline in their memory, but not change. There are people, and the estimate is about 30 to 40% of people with mild cognitive impairment progress on to have dementia. So it's seen as a potential precursor to the dementia developing. So we are now following people with mild cognitive impairment to see if they develop further damage to their brain. Dementia begins mild itself and then progresses until it becomes more severe, and actually people with dementia will die of their dementia at some point in their illness. We'll talk a little bit of that as we go along. So as I mentioned, dementia is not a disease. It's a term used to describe a collection of symptoms. The disease process that creates these symptoms is caused by some underlying problem. We don't know the underlying problems, but what we have done and what we've been able to do is group them to say the most common underlying problem that makes a person have dementia is Alzheimer's disease. And we'll describe all what that is to you. 70-ish%, this says 50 to 70 of all people with dementia have Alzheimer's disease. Approximately another 20 have vascular dementia, dementia related to bad blood vessels and blood supply to the brain. Another 15 to 20% have a disease called Lewy body dementia, and we'll discuss what that is. And then the last one on this slide says frontal temporal dementia. The estimate here is 5%. It's probably even a little less than that. So we're really going to focus today on the big three: Alzheimer's disease, vascular dementia, and Lewy body disease. All of those together affect approximately 5% of people between the ages of 65 and 74. But people over the age of 75 up to the mid 80s, it's approximately 15 to 25%. And of all people over the age of 85, it can get as high as 50% of those people have dementia. So you can see this is a huge problem for our older adults. It's a problem that increases with age. And so the older an individual gets, the more likely it is that they're going to have dementia. And if you were to look at a population of people all over the age of 85, half of them could have an underlying dementia. This is a slide taken from the Alzheimer's Association that looks at the number of people, not percentage, the number of people between 2010 and 2050 who have Alzheimer's dementia. And you can see right now, in and around 2020 on there, 5.8 million people in the United States have dementia. And you can see the breakdown based upon their ages. You can see that by 2030, 2040, and 2050, we will have increasing numbers of people who have dementia. That's due to aging and the fact that this disease hits people as they get older, and we have yet to find out how to fix this, find the etiologic cause of this. The different colors here show you different age groups, and what you can see is that 84 and 85 and over group getting bigger and bigger because they are, as a group, getting bigger and bigger in numbers. So by the end of this slide at the year 2050, we're looking at 13.8, close to 14%. 14 million people in the United States with an underlying Alzheimer's dementia, which is 70% of all dementias. So if you're looking at total numbers, you can add approximately another third to that. And the cost of that is unbelievable. And this is who's paying for care for this. And you can see the total numbers, the $1.1 trillion going in now, going by 2050 to care for this population. And these are seriously underestimated numbers because we certainly don't add into this the lost wages of caregivers who are providing that care, the money that caregivers themselves are putting into this well. So huge amounts of dollars going to care for this illness that we don't have a good handle on in our country right now. To understand it the best, you got to look at the brain and how is it structured and how does it work, so you can understand the problems that this has created. This is the most complex organ of the body. The brain is far and away harder to understand and study than any other organ. We don't have good testing for it. We don't have a good understanding of exactly how it works, and that's part of the problem of trying to figure out the dementia diagnosis and conundrum. In fact, my education leader when I was doing my geriatric fellowship, who was a neurobiologist who studied the brain, and I kept his quote because I thought it was pertinent. If the brain were so simple that we could understand it, we would be so simple that we couldn't. It is an incredibly complex organ. Let me show you what we know. Obviously, we've been able to take people's brains out and look at them. And so what we've done through the years is given names to the various areas of the brain. And we continue to find ways to describe this organ so that others can understand it. So we certainly have an idea of its overall general structure. We also know where certain functions live in the brain. We know that the eyes are up front and they're connected to the brain. And in the back of the brain is where all of the visual material that you see is processed. The motor ability to move your muscles is all processed in the middle section of the brain at the top. Memory is in the temporal lobe, that lobe here that is in the just above your brainstem and behind your eye. and then the frontal parts of your brain. So that's the memory-related centers. You can see a picture here that shows you where the pituitary gland is. That's labeled near the bottom. You can see near the bottom on the right-hand side a thing called the substantia nigra. That's an area of the brain responsible for coordinating movement, responsible for the disease damage there of Parkinson's disease. So we know not only the names of the areas that we've given them, but we know where, in general, certain processes occur based upon its structure. We know the cells that make this up, and we've given them names. That is called a neuron. That is the main cell structure of the brain. It has two key parts. It has an axon, which is a long off branch of that upper neuron that comes down to another neuron and communicates with it. So the axon is the communication arm of one neuron to the next. The dendrite is the shorter, smaller stalks that come off where the axon communicates to. So you can see that the axon is carrying a message from that upper neuron down to that lower neuron, and it attaches that message to the body of the neuron, but also on its dendrites. That connection, the axon and the dendrites, are all carrying information from one to the next and receiving that information electrically. There's electrical activity, there's electricity being generated in very small amounts that we can measure using a machinery called an EEG that look at how those electrical impulses are moved along. And that's how nerve cells conduct their communication from one cell to the next. Now, what's very interesting is if you look at where the two cells actually connect, and it's in a little white box at that bottom neuron, the axon sending information to that cell, the nerve impulse comes along, but that connection is not an electrical connection. Let me blow up that connection so you can see it. The axon at the top gives to the neuron dendrite at the bottom, and the electrical activity that is carried along is then transmitted information to that other neuron through what is called a synapse, and that information is transferred chemically. So the electrical information comes down, chemicals are then released, which go across a very tiny gap between the axon and the dendrite or the neuron, and that gap is then where chemicals are released from the axon to tell that neuron, here's the information I'm trying to send to you. A very complex system. You can see why it is really difficult to understand. And we've been able to kind of figure out some of the chemicals that are involved and some of the processes that those chemicals trigger. And we've been able to figure out how those chemicals get taken away, get destroyed once they're in that cleft between the two cells, or whether they're picked up by the following cell, and some of the actions that those chemicals cause. So the brain structure, as a big picture, we know where things happen. As a small picture, we know the cell types, we know the electrical connections, and we know the neurotransmitters, the chemicals that cross over a synapse to deliver that message. The neurochemicals, this is a list of the most common neurochemicals, and they're key to understanding our treatment or our thoughts about a variety of brain illnesses, but certainly about dementias. The dementia chemical we think that's responsible for most memory actions is the first one, acetylcholine. We believe the chemical dopamine is the one that's most responsible for the movement problems you see with Parkinson's. The others we think play a smaller role in those two diseases, but a bigger role in diseases like depression. So all of our drugs to treat the symptoms of these illnesses are designed to treat some of these chemical issues. Big picture, we don't understand a lot of stuff. We don't know really how memory is processed. When I tell you something and tell you to remember it, what is going on in those neurons? Is there a chemical made or stored? Is there a grid system that something picks up that chemical and does something? When I then ask you a day later what I told you yesterday, how do you get that back out? Do you go into that neuron and pull out a chemical? We don't understand that. That is the complexity of this brain. We don't really know on that middle bullet how those transmitters work. We don't know exactly the action that all those chemicals are and how they communicate. And there are certainly a variety of diseases like we're talking about that we don't know why you have them. We don't know why people have depression or schizophrenia. We don't know if it's a chemical thing or an electrical thing. We can look at people with those brains and not find absolutely any differences in any of the chemicals or any of the structures. So depression and schizophrenia are extremely difficult to figure out. Delusions or delirium and hallucinations, we don't know what causes those. We don't know how the chemicals are acting. And certainly for this presentation, we don't understand the memory loss and the progression of that loss that we're calling the symptoms of dementia. One of the things we do see is if we were to analyze the brains of people who died with memory loss that clinically look like they had Alzheimer's disease, they have changes in the brain that we have called plaques and tangles. Clever names, huh? But if you look at that picture, that's the pathology of a brain of somebody who has Alzheimer's. They have a plaque in the middle and tangles all around it. So Alzheimer's patients are known to have plaques and tangles in their memory areas of their brain. Is it the result of some damage? Is it the cause of the damage? We don't know that. Whereas people who have Lewy body dementia don't have plaques or tangles. They have an owl eye looking body that sits within their neuron. We call that owl eye body a Lewy body, described by Dr. Lewy, just like Dr. Alzheimer described the plaques and tangles. So they are different looking when you slice open and study microscopically the brain in individuals who have these kinds of diseases. That has given us a hint that the process that causes these diseases is different, even though the symptoms they're showing is very similar. That's why dementia as one word is the symptoms being displayed. However, underlying that or under the umbrella are the causes because they look different pathologically. They look different also in some of their clinical features, and I want to spend a little bit of time with those clinical features. So again, dementia, an umbrella term, describes a collection of symptoms. It's not one disease. It's a process that gives you the symptoms of problems with thinking and memory and behavior. And under that umbrella of causing those symptoms is Alzheimer's disease that gives you plaques and tangles, Lewy body disease on the right-hand side of the shaft of the umbrella, where you get Lewy bodies, vascular dementias. Those are the three big ones we're going to talk about. And there are two others, as I mentioned before. One I mentioned before is the frontal temporal, and then you can imagine a whole list of others. But the big ticket items today, Alzheimer's, Lewy body, and vascular. Can we treat somebody who has dementia and fix it and reverse it and it goes away? Well, not very often. But there are certain non-brain diseases that can give you memory loss. If your thyroid is way bad, you might not remember things well, and you might look like you have dementia. As I mentioned before, people who are seriously depressed could look like they have memory trouble. And I can give you medicines that can alter your way your brain thinks. So if you come in with some sort of memory-related changes, the first task the physician will do is search for anything that might be treatable and could stop this. Because all of the other diseases we're going to talk about are progressive diseases that can't be treated. There are important associations to understand. Parkinson's disease, as I mentioned, of the substantia nigra, the center of the brain, thought to be related to dopamine problems. People have a dementia associated with that. So there is a relationship between people having Parkinson's and people having dementia. Patients with Down syndrome are adults at the ages of 40 and 50 who develop dementia. So there's an association between Down syndrome and Alzheimer's disease in particular. So that's one that we think about. And then a very interesting illness called Jakob-Creutzfeldt disease. You'll know it by the name mad cow disease. This is an illness where if you happen to be exposed to a cow brain tissue, you could develop a dementia, and that was found to be due to actually an individual little infectious disease particle called a prion. People go from totally normal to dying with this disease in 1 year. So it is an unusual association some people have heard of, so I throw it in here to be complete. It's not going to be any more discussed. We're really going to look at Alzheimer's, Lewy body, and vascular disease. These are the percentages, and let's talk about each individual one. So Alzheimer's disease, the most common, 70% of people with a dementia have the pathology in their brain that Alzheimer's discovered in 1906, plaques and tangles of the brain. Clinically, they have symptoms that show the short-term memory impairment, the language impairment, the visual spatial impairment, as we've talked. They have absolutely no findings in motor problems or sensory problems. The disease starts very mild and gets worse slowly and progressively over years. People can live with this illness for 15 to 20 years. The classic example was Ronald Reagan, who died with Alzheimer's disease. He had Alzheimer's plaques and tangles in his brain. That started 10, 15 years before he died. And he was extremely functional early with this illness and had lots of help to keep him on track with his short-term memory or language impairments. Alzheimer's pathology, as I mentioned, creating those plaques and tangles. Those plaques and tangles are made up of a chemical called beta amyloid. It's a protein. Is it causing the destruction of the neurons, or is it a result of the destruction of the neurons caused by something else? We don't know the answer. We think it may be etiologic. It may be the thing damaging those neurons. There are certainly neurochemical changes that go on, and I mentioned already the main neurochemical we focus on is acetylcholine. Beta amyloid is a small 40 amino acid protein that near the letter B in green says unfolded. That's the individual protein. But it can be found in the brain in multiple structures. It can be partially folded as a helix. It can be hairpins. So it's a complex cell protein that seems to damage somehow, as it proliferates, the neurons of the brain. We know that people who have Alzheimer's and have illnesses that create more beta amyloid get Alzheimer's earlier. We know that beta amyloid can destroy nerve cells. We've been able to test that and prove it can destroy nerve cells. So the best culprit right now being studied extensively is the role beta amyloid plays in the creation of Alzheimer's disease. Alzheimer's disease is not usually diagnosed by biopsying the brain. If you want to absolutely say this person has Alzheimer's disease, they have to be classically showing you the symptoms and you have to do a brain biopsy. Most times that doesn't happen. So most of our diagnosis is this is most likely or probable Alzheimer's disease. A classic picture, but we don't have any brain biopsy. Possible is we don't have a brain biopsy. The picture isn't clear, it's not perfect, but that's the most likely thing because there's nothing else that's likely. So we will give it a probable, possible diagnosis of Alzheimer's. And most people don't say those things as a physician. They say, I think this is probably Alzheimer's. The plaques and tangles in the normal brain occur in the temporal parietal lobe, that's here, and at the base of the frontal lobe, that's here. So as the disease progresses, you find more and more of these amyloid plaques and tangles. They spread throughout different parts of the brain, early disease, moderate disease, and severe disease. And so that progression causes more and more symptoms in the individual as the neurons are damaged in those areas. Differentiate that from a different illness causing the dementia picture, and that's Lewy body dementia. As I mentioned before, the Lewy body is an owl-eye-looking spherical body within the neuron that contains a different kind of protein, not beta amyloid, a protein called synuclein. And it's within the body of the neuron, but that neuron then is no longer functioning. So like Alzheimer's, the symptoms you see are a dementia, a memory loss, visual spatial loss, loss of language, loss of calculations. The individual that has been talked about the most related to this is Robin Williams, had bad Lewy body dementia. It's a much more rapidly progressing disease, whereas Alzheimer's is 10 to 15 years. This illness is 6 to 8 years until it takes over and damages enough of the brain that people could die from it. Lewy body dementia at the bottom has a lot of names. You might have heard Lewy body disease or diffuse Lewy body disease or Parkinson's disease with dementia. All of the names get a little bit mixed up, but they mean the same thing. The patient individual has symptoms of dementia, but rather than have plaques and tangles, they have these Lewy bodies as the degenerative look on the histology at a biopsy of the brain. And that's the protein and the vacuole of the Lewy body. There are some clinical features when you meet a patient who has an onset of dementia and you're trying to say, could this be Lewy body or is this Alzheimer's? In that the Lewy body patients exhibit some motor changes. Alzheimer's patient has no motor changes. And the motor changes, the ability of the muscles to work, looks like they might have some Parkinson features. They shuffle, they have difficulty initiating movement, they have some muscle stiffness, rigidity, tremor, they have a masked faces, typical characteristics that you would say, does this person have Parkinson's disease? Because the same damage that creates the Lewy bodies in the area of the memory cells is the same damage creating the damage to the substantia nigra in Parkinson's patients. So there's an overlap of those illnesses. These individuals have more complex visual hallucinations early in the disease. So an individual whose memory isn't quite right, who you're testing, who has features that suggest that they have some motor findings or more hallucinations, would be someone you would say, aha, I think they have Lewy body as the underlying cause of their dementia. The third category that again is about another 15 to 20% are people with small strokes in the area of the brain that affects their memory. These are not large strokes, these are tiny strokes. So they're called multi-infarct or lacunar, small strokes. And we use the language of lacunar strokes. So these individuals have small strokes in memory areas, the same areas that I showed you of where the plaques and tangles are occurring in Alzheimer's patients. But they don't have plaques or tangles. They have neurons that have died because they're not getting enough blood. These individuals clinically have symptoms that say they have other signs that would make it such that you would suspect they might have small strokes. They've had other big strokes. They have high blood pressure, coronary disease, smoking histories. They're individuals who have an onset of memory and these other things. And so you would categorize them as they probably don't have Alzheimer's, they have multi-infarct dementia. One of the big differences is the timing of these two illnesses. Alzheimer's disease is a slow, steady decline in ability. Over time, those plaques and tangles spread. They damage the brain cells. You get progression that's slow and steady. Whereas multi-infarct dementia, more infarcts start happening. So they are stable for a period of time and then get worse for a period of time. And then they stabilize for a period of time and then they can get worse as more infarcts happen. We describe it as a stair-step change in their mental abilities, whereas Alzheimer's is a slow, steady progression. So you have an individual who has memory trouble and you're trying to figure out what's going on. We do a lot of testing of the brain. The two most common testings are called a Mini-Mental Status Exam or a Montreal Cognitive Assessment. They're both questionnaires to try to ask you and test how is your memory working? Can you answer these things? We look not only at memory, but we look at visual spatial things. We look at language things. Out of 30 points, how many points can you get on a mental status exam? The MoCA, the Montreal Cognitive Assessment, is another type of questionnaire. The middle section you see is animals with you naming those animals. Our attempt to try to understand, have you processed the memory of those names and been able to give it back to us? Both of them have new recall, giving you new information to recall back as a quick memory, short-term memory test. So we would administer tests like this to see how your memory functions. We could ask you, and will ask, to draw a clock. Here are examples of people who've attempted to draw a clock face, making the hands at 220 and see what people draw, because your brain has to process the information and draw it back, and that tests both memory and visual spatial testing. So we can do those kinds of things. Series testing is how many ways using coins, US coins, can you create a dollar? 10 dimes and 4 quarters and 100 pennies and keep going. And the brain of a normal person can come back with 8 or 10 different ways to do that, whereas an individual whose memory is fading, is damaged, will have trouble remembering the task, attending to the task, and completing that series test. So we've done all that testing and determined you are not normal. You have an abnormal memory pattern. You have dementia. First thing we're going to do is a bunch of blood tests and scans and look to figure out, is there something we could fix? But more commonly, we can't. And then we're going to try to classify it as which of these do we think you have? And the simple way to do that is in the exam itself, in the cognitive test itself. If you're saying back to me, I don't know that, I'm not sure about that, people who are demented don't do that. They do not recognize they don't know. So if that's their answers, they have some other illness, frequently a depression. Then we go on to do our lab tests and say, you don't have a treatable cause. There's not a lab abnormality or medicine that's done it. You take everybody else and you say, is there any evidence they've got vascular disease? Have they had strokes or hypertension or smoking? Is this progression look to be stepwise or is it smooth? If it's stepwise, they have significant vascular disease, it's likely they got vascular dementia. Do they have any motor findings? Do they have any features that make you think it's Parkinson's? Are they hallucinating more? That's a patient who probably has Lewy body disease. And then everybody else has Alzheimer's. That's the state of the art right now of how we diagnose these three diseases. Clinically, what are the presentations and how do we break them in? So that's where I'm going to end. We've looked at dementia, delirium, mild cognitive impairment, normal age-related changes to the brain, the structure, function, location of memory and the diseases of the brain. We've talked about how you evaluate somebody with memory loss and then the different types, major types of dementias that underlie that. An umbrella diagnosis of memory loss, multiple causes, and we can figure out as best as we can what's the most likely cause of those.
After that, we have a few questions from our participants. The first one is it important to consider a durable power of attorney for someone who has been diagnosed with progressive cognitive impairment?
Absolutely. In fact, anyone who presents early with a diagnosis of dementia should have a durable power of attorney. Now, I've spoken before to many here and said it's my belief every person should have a durable power of attorney. I don't care whether you have an illness or not. You should write down your wishes for your end of life and make sure you assign an individual to make decisions for you should you be unable to do that. Because at the age of 23, a car wreck could take away your decision-making ability. So at any stage of your life that you have the ability to think through problems, you should have a durable power of attorney. Once you start developing a dementia, you need to start filling it out then, because you will lose the ability to make good decisions as that brain deteriorates further.
Next question, can someone who has been diagnosed with progressive cognitive impairment safely remain in their home?
So the loss of function that's going to happen as everyone has progressive dementia, they will all need help with their instrumental activities of daily living and their activities of daily living. They need help with their function in and around their home as these diseases progress. And so caregiver-like services will become necessary for these people. Is that caregiver a family member? Is that caregiver a neighbor? Is that caregiver someone hired from a company? Caregiving is a huge issue in our communities. Many patients find caregivers by going to a location to live, like a residential care facility where there are caregivers there and they're living outside their home. If possible, hiring caregivers into your home. And I think most of you are aware that Livingston has a tremendous caregiver service. So as these diseases progress, caregivers become necessary.
Next question, if my loved one has been diagnosed with Alzheimer's, what type of clinical support should I seek to ease my loved one's journey?
So Alzheimer's disease is a long disease. It's the longest of these diseases. So people will live the longest, usually 15-ish years, with progressive loss of their memory and their abilities. Seeking and looking for what's available that can help you help that individual. There are a lot of resources in this community and in any community people live. I would begin by seeking advice from your physician. I would add to that the Alzheimer's Association. I would add to that the 211 listings. I would add to that, Livingston services know a lot of what's going on in the community. But if you have questions about what could help you, you need to turn to those kinds of resources to find out what's available and how you can best care for your loved one who's progressively going to lose their memory and function.
Thank you. This is our last question. This is Dr. Dial with regards to vascular dementia. This makes me think I should run 30 minutes a day, 6 days a week to increase movement and, in quotes, clear the cobwebs. Does this make sense?
So you hopefully tuned into my aging talk. If you didn't, it's available on the Livingston website. But my huge push to any group of people is exercise will keep your body aging well. It helps not only your physical body, but it helps your brain. And we're not exactly sure how. Some of the images discussed are, if you think of a screened window as all the neuron connections in your brain, and you think how big are the holes in that screen. And if your holes allow the passage of a grape versus having a screen where the web connection is much tighter so that a mosquito can't come in, you can take one type of structure where a grape can go through and turn it into a screen where only a mosquito can't get through, even a mosquito can't get through. And if you visualize that as the connections of your brain, you've created many more neuron, axon, dendrite connections, and maybe all the damage that's going to happen will be mitigated by having more connections. Now, no one's proven that analogy, no one's proven that idea, but we certainly are huge advocates for continuing not only physical exercise, but brain exercise, keeping people active, alert, reading, interactive, doing puzzles, playing bridge, as long as they can, to keep the connections in the brain tight and the chemicals moving and flowing so that when damage happens, it's not creating as many symptoms.
All right, I think that's all the questions we have for today.
Thank you very much. This will be posted on the website.
We will also include a link to Dr. Dial's past Aging Well presentation for those of you who are interested in watching them. Thank you so much. Have a great day. Bye-bye.